Today we're going to talk a little bit about how to approach ceramic inlays and onlays on teeth. And one of the things that's really important in this whole process is the diagnostic aspects. Of course, we can consider the aesthetics and see that the existing restorations fail to meet the patient's aesthetic expectations. So that's one definite reason to perform ceramic inlays and onlays on patients. But another, of course, is to reestablish the form and function of the teeth and to replace existing restorations that are defective for whatever reason, whether it be a fractured cusp or fractured restoration, recurrent caries, erosion, or anything of that nature. So today we're going to go through the process of how to disassemble an existing restoration which fails to meet the demands of the patient and our own particular standards, and go through the particulars of a step called the blockout, which is not a build-up and it's not a base. It's something different perhaps, but it's used to replace missing tooth structure. And we're going to talk about the material selection in that particular process. We'll talk about the preparation design for inlays and onlays, and some of the variations that you might encounter in order to provide restorations of the highest quality. The particular ceramic material system you use is not nearly as critical. All the preparations we're going to be discussing can be utilized with composite restorations, indirect, or Emax, or any of your products that are made from ceramic feldspathic systems, or even the more older but wonderful lucite-based ceramic inlays and onlays. So it's really not so much material specific as it is more of a material generalized approach, because what I'm going to discuss with you works with any of the existing ceramic indirect systems available. So we'll get right to it. We'll start with a quadrant.
Okay, so here's a quadrant that we have, and it's on a type-it-on, of course, but we're simulating, for the purposes of this demonstration, amalgams on the molars and composite restorations on the premolars. And our assumption is going to be that all of these restorations are failing for one reason or another, whether it be recurrent caries, aesthetic embarrassment of the patient, or some other problem with the tooth or the restoration. And our plan is to do different types of ceramic restorations on each one of these teeth. We'll do a simple DO ceramic inlay on the first premolar. We'll do an MOD inlay with maybe an onlay of the facial or lingual cusp or both. We'll do an inlay-onlay restoration on the molar, and then we'll do an inlay with a half-crown technique on the second molar. All of these preparation designs will work for any of the restorative materials that we have available, whether it be a glass ceramic material or feldspathic material. So your Emax, your lucite-based products, and even your composite-based systems should all work with the preparation designs we'll be discussing. Before we do the preparation designs, we're going to want to disassemble these restorations. We're going to want to remove the amalgam and obtain a dento-enamel junction that's completely clean of all stains and any problems. We're going to want to remove any decalcified enamel, stained enamel around the periphery, and then remove caries internally as we find it. We're also going to be looking underneath the cusp for any fracture lines or stains that might indicate that there is a cusp that's weakened. And then we'll be making a decision as to how to build the tooth back up to full contour prior to starting our inlay-onlay restorations. This technique that I'm referring to is called the blockout technique. After removing the existing restorations, this disassembly procedure will be utilizing several dental materials to replace the missing dentin, missing tooth structure, before we start our preparation. And for our purposes, I think that this molar would be a nice choice to start with. So we're going to start on the first molar with the disassembly and the blockout procedure. One of the other diagnostic adjuncts that we have is this little tooth sleuth, and I've just entered it into the frame here. You can see it. It's a piece of plastic that has a pyramid type shape with a little recess at the top of it, and this is utilized to place on top of cusp tips and have the patient occlude and squeeze and see if there's any pain elicited from their biting. And the other side, I'm spinning this around here, is just more of a pyramid shape that you can put into the fossa areas. So before we do any of these restorative procedures, we want to have a thorough diagnosis at the very beginning, and we can enhance our knowledge by utilizing the tooth sleuth, having the patient bite down and then release, and if we have any symptoms, so we know that we may be dealing with a more serious issue of cracked tooth syndrome, or we may know more information like, for example, if I were to put the tooth sleuth on this distal lingual cusp and the patient were to bite down and this elicited discomfort, then I would know that that distal lingual cusp itself was fractured, and I would have to deal with that area of the restoration differently. I could perform this tooth sleuth procedure on other cusps and elicit no response and know that I wouldn't need to do anything on those particular cusps. They could perhaps be inlaid, where the cusp that was responding would need to be removed or onlaid. Okay, I have a diamond burr in the handpiece. This is a pear-shaped burr. It happens to be made by Brassler Company, and it's called the 830L012. 830L012. It's diamond-shaped. It's about 3.5 millimeters long, about a millimeter in diameter, 1.2 in diameter, and it's pear-shaped and round-ended, and this is perfect for removing old restorations. And the fact that it's pear-shaped allows you to get up underneath the restorations. Okay, at this juncture, we've removed all the existing restoration in our disassembly procedure, and at this point, it's important to make sure that you get a DEJ all the way around the preparation that's completely free of stain. Now, it doesn't matter if the stain is hard. If there's stain in the DEJ, the dentin is altered and it's more prone to recurrent decay, leakage, and problems. So let's make sure that we remove all the stain completely from the DEJ. Now, stains in the internal portion, on the pulpal wall, the axial walls, if they're hard and you deem that they are not carious, they can be left behind with no consequence. But it's that DEJ that has to be stain-free. You know, at UCLA, we tell our students, make that DEJ squeaky clean. And it takes all the worries out of whether you've left decay behind in critical areas or not, because now we can focus our attention on the slow speed areas, the spoon excavator areas, that being the pulpal wall and the axial wall. In this particular situation, I think there might be a little bit of a stain left at the DEJ, so we're going to go ahead and clean up that, and then we're going to remove some of the caries here on the mesial with a round burr before we proceed with the block-out procedure. We now have the DEJ completely clean all the way around. All of the old restorative material is removed, and we've actually spent a little bit of time looking underneath the cusp for cracks. And fortunately, we haven't found any cracks at all. So this particular inlay looks to be an inlay in this area, and maybe an onlay over the distal lingual cusp, because as we had simulated earlier, that we had suggested that there might be some pain when the patient bit down in that particular area. So that gives us a lot of information. Now it's time to use a round burr. And a round burr will not be used to remove enamel. It won't be used to change the DEJ. The round burr is used to remove soft decay in the areas of the pulpal wall and the axial walls, wherever those axial walls are located, whether they're interproximal or out here on the lingual side. So we'll utilize the round burr because of its improved tactile sense and remove the caries. Okay, we've now removed all the caries. You can see that the DEJ is clean, there's no caries left behind, and we placed a standard Toffelmauer matrix band and retainer with some wedges on the lingual side to stabilize the area before we place the blockout material. We're now ready to place the blockout. The blockout is a two-step process. The first step utilizes a resin-modified glass ionomer liner, which will adapt really well to all the irregularities of the surface. The second step is the use of a resin-modified glass ionomer that is a restorative material. In other words, you could use it to restore class 5 restorations. It's more highly filled, and it actually works well because it's more machinable. So when we're cutting the preparation, we want to be feeling that hard surface like we would if we were cutting two structure. We don't want the blockout material to be too soft. So we use a two-step process. The more flowing material to fill in all the nooks and crannies and the irregularities, and then a thicker material to fill on top of that. If we were just to use the second material, the resin-modified glass ionomer restorative, that material will be too viscous to fill into the irregularities up underneath the cusps and in the areas where we removed caries. We've dispensed a paste system of a resin-modified liner, and we can mix this very rapidly on the pad with a small little instrument. I love this instrument. It's called a Bertels applicator. It's got a small spatula on one end, and the other end has got this little die-cal type instrument used for placing the material in hard to get to areas. So we get a nice uniform mix, and now we're ready to pick up a piece of this and then apply it into the cavity for the initial first step of the two-step process. So now we're applying the more flowing material, the glass ionomer liner. And you can see that you basically get a little blob of it on the end of the instrument. It just flows into irregular surface areas. It's not that you're trying to coat all the dentin, it's just that you're trying to get it into the irregular zones before you light cure it. And I think that that'll be about the right amount. So now we're ready to light cure that. Okay, now we're ready to do the second step, which is the placement of the resin-modified glass ionomer restorative material. This particular restorative material is supplied in these easy-to-mix caps. And we're going to go ahead and get the tip all the way down onto the pulpal wall and express the material. Now, we're using a dark material here so that it'll show up in the photography better. We could certainly use a material that's a little closer to the tooth color, but in many respects, having a difference is helpful when it comes to prepping the tooth. And then we use a plastic instrument to just quickly apply it. This is not a very sophisticated step, and we're not really trying to do much carving of anatomy. We're just filling in the tooth. It is helpful to find your margins a little bit and keep the margins somewhat clear of excess material so that we don't inadvertently over-prepare an area. There we go. A lot easier than placing a composite. Very simple step here, really. And this is the second step of the blockout procedure with the resin-modified glass ionomer. Very quick. In fact, if you run short on time and you're doing a whole quadrant of these, you can actually remove the amalgams, remove the old composites and all the decay, do the initial step with the more flowable material, the glass ionomer liner, followed by this glass ionomer restorative material, place it, adjust the occlusion, and allow the patient to leave and come back for a future visit. They'll be very comfortable. They'll be able to chew on these teeth without too much difficulty in the interim. It's not very strong. It won't hold up quite so well for too long. But for a few weeks, it's very serviceable. And when the patient returns, rather than doing any clean out, you already know everything's been cleaned out and disassembled. You've already performed your diagnosis, and then you can just go ahead and rapidly proceed along with the entire quadrant, which is exactly what we're going to do. So the next image you see will be all 4 teeth cleaned out with the blockout already in place, and we'll go ahead and prep the entire quadrant for you to see the inlays. Okay, so here we are at the appointment ready to do the porcelain inlay and onlay preparations. Well, specifically, let's call these EMAX or ceramic inlay onlay preparations. We have a series of burrs here, and each burr has its own purpose. The burr here it's a tapered, round, slightly round-ended diamond burr, and it's a little bit wide. It would be good for the isthmus and wide isthmuses. And this burr right here is referred to the 845 KR016 made by Brasseler. This is the 88 KR 016, and it's also made by Brasser. You can see by the red stripe that this is a fine grit diamond. The diamond particles here are 30 microns. The diamond particles here are 100 microns in diameter, so they're very different in what they do for us. A couple of burrs that are in the similar line, but these are longer and more narrow. They've got a little flat end on them with a slightly rounded corner, so they're really good for ceramics. And this one right here is referred to as the 846 KR 012. And this is the 8846 KR 012. So these are great for getting into narrow spots, perhaps dropping your box and getting your extensions. And then finally we have a diamond ET burr, an ET6 burr, but this is a diamond version. It happens to be red striped, so it's fine grit as well. Great burr for rounding off sharp edges on axial pulpal line angles, for example. It's great for breaking contact with the adjacent teeth. So it's very, very helpful for us for these preps. So we're going to go ahead and show you how these preps are utilized in a quadrant. So here we are with a sample quadrant. These are 2 premolars and a molar. They've all been, the prior restorations have been removed, and the blockout procedure has been accomplished as we discussed in the last video. We're now going to be performing 3 porcelain procedures. These could be used for whether they're milled or they're pressed. In other words, whether you do a CAD/CAM technology with ceramics or you're doing these as indirect restorations, we're going to follow the same preparation design. We're going to perform a DO inlay on the first premolar, an MOD inlay on the second premolar, then we'll do an onlay, and then we're going to do an MOD inlay on the molar with a lingual extension and an onlay of the distal lingual cusp. So we're going to go ahead and start off with the first burr, which will be really the workhorse. We're going to prep all 3 of these teeth at the same time in the same sequence with the same burr. And so I'll do all of the occlusal surfaces first, and then we'll drop all of our boxes, and then we'll do our refinement at the end. So you'll see this done in a very efficient manner. So we're going to go ahead and start off with this 846 KR burr as from Brasser. We're going to hold the burr so it's along the long axis of the tooth, and I am on the video, so I'm going to be moving this in and out a little bit. There will be times when it'll be a little harder to see, and I'll move the burr to show you the effect of that particular movement. So perhaps if I turn the type on a little bit in the view this way, I think you'll see a little better. So our preparations are going to be approximately 1.5 millimeters deep. And we're not going to really worry too much about the draw at this point. We're mainly just trying to get the depth done. So we're going to go ahead and make these at that 1.5 millimeters of depth all the way across. So I know that I've got the depth about right, because I know that the burr is approximately 4 millimeters long, so I'm using a little less than half the length of the burr to get this initial part done. So it's very quick, and we don't want to spend too much time on this because we're going to be doing some refining as we go along. So now at this point, if we've got this depth done, and of course you could use a different burr, a burr that has a known depth of 1.5, like a 330 burr, is an excellent option for this particular step. So we'll go ahead and at this point, once again, holding the burr along the long axis of the tooth, we're going to go ahead and start, or the crown of the tooth more correctly. We'll start our procedure. And remember that a ceramic restoration cannot have beveled margins. All the margins have to be 90 degrees, or a butt joint margin. We don't want to have the preparation too tapered because we'll lose sight of the fact that we need a butt joint margin. So if we were to, in this particular area, tip the burr over this way too much towards the facial, we would end up having an interface that would create a ceramic inlay with a very acute angle of ceramic. So it's best to keep it fairly straight up and down. The taper and the burr is probably going to be enough. I find this to be true of the newer ceramic products, like Emax, for example, that we can have a preparation that's actually a little less tapered, a little more parallel, because when we used to do ceramic inlays, feldspathic inlays, the preparations would have to have draws that were perhaps a little bit more than you would have for a gold inlay. The material was weaker, and we were afraid of having it break. So we wanted to seat easily, but we still were left with a very acute angle at the cable surface margin. But the newer materials, not so the case. So we can just use the burr to accomplish most of the draw taper that we need in the preparations. And so we're just going through each one of these, and we're keeping the burr fairly straight, letting the burr do the work, and attempting to keep the pulpal walls fairly flat. Of course, you don't want to have any of the blockout material on the margin of the final preparation, on the cable surface margin or the finish line of the preparation. So once again, all of our angles for the boxes are being established before we drop the boxes. This is such an efficient technique. Several years ago, I'm going to say probably close to 22 years ago or so, Dr. Richard Tucker, a very amazing operator, a great teacher, a clinician from Ferndale, Washington, taught me a lot about gold inlays, and we've continued to be friends over all these years. And one of the things he said is, do things the same every time, and you'll be more efficient, and follow a stepwise approach. And when you've done each step the best you can, your final product is the best you can achieve. So you don't have to keep doing things over and over again. So let's take a closer look at some of these preparations at this stage. All right, so here we finished the preparations, but we did encounter something kind of interesting. These are extracted teeth in a Typodon, and even though we try to keep them moist and flexible, we had this happen, which shows you that a piece of the tooth has broken off. Now, could this happen while we're working clinically? Absolutely. So what we're going to do is we're going to modify this preparation on the molar to include the facial cusp, and I'm going to show you how we would make that particular change. Okay, so you can see the buccal cusp missing, and we can turn the Typodont sideways here. You can see that it's been fractured all the way down to the level of the rubber dam, and it's undercut. So you may be wondering, oh my goodness, what do we do about this? And my recommendation would be stay true to the technique. Go ahead and drop all your boxes, complete your preparations, and then worry about onlaying or wrapping around to pick up on these little defects. As a separate procedure done at the very end. It keeps you very efficient, and it keeps you focused. Because something like this comes along and it can very easily distract you from the basic, the fundamentals of getting the ceramic preparations completed. So let's go ahead and finish up the boxes at this point. So I'm going to use the 846 burr, which I have over here, which is a longer version of the burr that we were just using. It's diamond, it's got a flat end on it, so it's good for creating a butt joint margin, and is slightly rounded. Okay, so we're going to go ahead and use that right now to drop the boxes. We want to keep the axial walls approximately 1 millimeter deep. And make sure that our margins are completely on tooth structure and not on block out when it comes to the margin. And you can see we're not really extending the outline at all. We're utilizing the existing flares that we've created, the extensions, for the perimeter, the proximal perimeter of the press. It's kind of neat. You don't have to worry about the box. The box is, in a sense, it's already been completed. You've already done it at the occlusal. So one of the dreaded portions of a Class 2 is performing the box. And you can see here, it's just not a lot of effort. And I think it's because we spent a lot of our time early on getting that taken care of. So we'll do our box. We won't worry about that buckle at this point. And the final box. Let's see if I tip that for you, you can see that a little bit better. You may wonder, oh, what do you do about this? Well, that's later. This is an additional procedure that would be handled later, along with the lingual cusp here, distal-lingual, and the mesial buccal cusp. And we're going to also onlay this middle premolar. So the boxes are nearly done. There's going to be some finishing work that we'd have to do. So let's just spend a few minutes finishing the boxes and making them nice and refined, and make sure that everything has proper taper. One of the things that's kind of important is to take your axial walls and, we say divergent occlusally. A divergent occlusal box is at times difficult to visualize, but if I just can think of it as have the axial wall lean back in towards the center of the tooth, that I can really very quickly imagine. So we like to lean the axial walls in towards the center of the tooth, and it's remarkable how the undercuts just disappear when you do that. So this is the distal, and we'll just lean it towards the mesial. Lean it towards the mesial. Do we need to break contact with the adjacent teeth? Absolutely. You don't want to leave any tooth structure in contact with an adjacent tooth. You want to give the laboratory ample room to place their die saw and make individual dies. If you're doing a CAD/CAM direct procedure in the office, you want to be able to scan your margins through your optical scanning without any interference from an adjacent area tooth. Much easier to do. So there's really no advantage to leaving them in contact, as you might do with a direct composite. But indirect, we really need to break our contacts and give ourselves the best possible chance of a good fitting restoration. So I'm going to switch over to the 88 burr, 8846, because the 8846 has fine diamond particles and will give us a little smoother finish. So we can now just take our foot off the foot pedal just a little bit, slow things down, and start doing refining everywhere. Okay, so we've finished the basic preparations, the DO inlay, the MOD inlay, and the MODL inlay on the molar. So now let's go ahead and make the modifications. Well, the inlay here is completed in terms of its basic preparation. There's a little bit of things we're going to do at the end. I'll talk about those. But now let's go ahead and do the onlay portion. Okay, so now I'm going to utilize a burr called the 845 KR016, and the 1.6 means it's 1.6 millimeters at its widest point. So that'll give us a good idea of how much we need to reduce. And if we're utilizing a lithium disilicate product like Emax, we can get away with about 1 millimeter, but 1.5 is probably safer. So we can actually use this burr as a depth cut. So let's go ahead and do that. We're going to pretend as though this cusp were needed to be onlayed for whatever reason. So we're just going to lay the burr at the angle of the cusp and just go ahead and take it down to the full thickness of the thicker part of the burr and just bring it across. And really this is just so easy that you can do an onlay. It doesn't take a lot of effort really. And that's the end of the onlay. Now, if this was thinner, you might need to wrap this around, or if you needed to wrap it around and blend it on the facial for a different reason. But I don't know if you can see that, but you see how we've maintained the shape of the tooth with that particular onlay procedure. That actually really looks good when you can do that with an onlay, and rather than going straight across, because there's usually a little bit of a demarcation line. Certainly a different translucency between your product, your materials, and the tooth structure. So if you can have it follow the shape of the tooth, it tends to look a little less noticeable. All right, so now let's go ahead and onlay the lingual cusp. And the lingual cusp onlay is going to be done we're going to go and show you a butt joint style. So we're going to do 2 planes of reduction. We'll do one here. We're going to go ahead and put the burr down to the level of the depth of the flutes, bring it across, and knock off all this here. There it is. Okay. And in many situations, that's it. You're done with the onlay at that point. You don't have to do anything further. But because it's sort of a fun thing to do, and occasionally you will need to wrap around, we're going to show you this wraparound effect. But I think laying it over like this is enough. In most of the situations, but some of you probably want to know how would you handle a butt joint margin on an onlay. I was taught that in school, or I've seen that in other courses, so I'm going to just show you that portion. We'll just go ahead and go into the axial wall of the tooth and bring it all the way around to the mesial and all the way around to the distal like this. And this is the shoulder effect, if you will. So you can see how that will create a shoulder design there on that lingual margin. So we'll just stop with that prep at this time. Now let's go ahead and do the molar. And the first thing I'm going to do here is I'm going to take the burr on its side and just get a nice finish line down here in this OL portion. You can use the burr on the wall and come down this way. I like having this finish line slightly rounded. It makes for a very nice looking finish line. It's easier for the technicians to wax to, and we don't need any retention elements in there at all, so having that like that is just so nice. Really a straightforward technique, not the technique that we were probably taught, many of us at school, to come in with a box and make it like another box form here. We don't need to do that at all. And then, so the lingual cusp, we have adequate tooth structure, but we're going to assume that needs to be onlayed. So once again, use the burr, the full 1.6. And remember, you're doing this with a rubber dam on. You're not checking the occlusal clearance. We're relying on the thickness of the burr to get the depth cuts that you want. And there's the end of that particular onlay. Okay? Now we're now left with this little feature over here. And because this mesial buccal cusp is severely undermined, we're going to go ahead and remove this undermined enamel, and then let's see what we have. So that's the first thing. Let's create some draw here. So we're going to go ahead and just remove the undermined enamel. Okay? And that So we can see our preparation. That's a nice first step to do. Okay, so now we can see that that's been removed. And now it starts to become a little bit more clear what we can do. Let's take this gingival area, which is fractured off in kind of an oblique manner, and just make that more of a butt joint, because that's a requirement of our ceramics, and blend it with the box on the mesial. So now we've just connected that across, just like that, like we're doing a full coverage Emax crown. So this portion from here to here, I should show you this way, from here to here is like a full Emax crown. And this is like an onlay coming over. And now it blends into an inlay. So all of the principles have been met by doing it in that particular manner. I hope you can see that. So this comes across. Now, if you don't like the fact that this is halfway through a cusp, and you'd like to change this because you're afraid of this being weak, no problem. Go back to onlaying. So let's go right in the groove area, and I like going down the middle of the groove, right? Right down the middle of the groove, because you don't want to go right to the groove. You'd have a margin that was in a ditch. And then go ahead and bring it across and knock off that cusp. Easy. Really, really easy. Just like that. So now we've done an onlay on that facial too, that where the lithium disilicate will wrap over the facial and then blend down into this area here on that facial area. It's kind of cool. So that's really essentially how I would handle it. There's many different ways, I'm sure, but that's just one of the many ways. Now, at this point, let's go in and show you what this looks like, and then I'm going to show you the final finishing procedure. Probably one of the most important steps is to show you how to make all these line angles flow with each other, so no sharp angles on the exterior outline form. Okay, so we've done the DO inlay preparation, the MOD with the onlay, and then we did the shoulder, and then we've done an MODL with an onlay distal lingual and an onlayed mesial facial wrapped around more like a crown, and everything seems to draw reasonably well. But the problem with these preps at this point is they just don't have adequate flow from one area to another. For example, if you go across this lingual, there's a sharp edge here before it drops down into the box. And there are also some sharp edges here, which in a cast gold restoration would be perfectly acceptable, but not optimal, even for cast gold. Internal line angles for cast gold would be sharp, external would be blending in a smooth manner. For ceramics, we want internal line angles rounded and external line angles rounded as well. So here's what we do. On the inlay preparation, the only thing we're going to need to do is we're going to have to bevel the axiopulpal line angle. So I'm utilizing a burr called an ET6, but it's called a DET6, D for diamond, and the ET6 can be used because you can fit it inside the prep easily, and we can take this sharp line angle and just round it at the axiopulpal. And then we can do the same thing. Let's just round off all the axiopulpal line angles. Round off the next one. And then come across and do the next one. So we're doing all the internal rounding. Get the line angle here on the distal, and the line angle here on the mesial of the molar. Okay? Now, that part's done. So we don't have anything further to do on the inlay. It's completed. Butt joint margins, rounded line angle, we're finished. We cut this preparation with a burr that has a rounded diamond end. It's pretty sharp compared to maybe a perfectly rounded diamond, but it's a flat-ended round. This is not nearly as sharp as it would be in a gold restoration. Our ceramics today are very capable of handling that kind of a interface. So here's how we handle the onlay. The important thing is the onlay has got to have a bevel here between the onlay and the inlay. So that's rounded, and that's easy enough. And then we'll do the other side, same thing. Round off this part and this part. Right? So that works out nice. And we can do the same thing on the molar. We have a small little onlay here, but we can't forget to round it off. And then we round off this little onlay area here that wraps all the way around. All that part. You see, we're doing it very systematically. And now finally, that we've done the internal forms of the axial walls, we've done the internal forms of the onlay preps, excuse me, then we'll go ahead and do the transitions from the facials to the proximals. And so in this case, we just may have to do a little bit of this, just to round that over, and a little bit here. We don't need to do it on the inlay, it's already done. And then we're going to go ahead in this particular case and go ahead and blend it here as well on the lingual and on the lingual. So look, this is the shoulder going into a box, and this line angle right here, this point, can't be sharp. So that gets rounded like that. And this gets rounded like that. And so we'll go ahead and do that wherever that occurs again, which would be here. Whenever you go from an onlay to a box, you must blend the transition into that area. Just to double check, are we smooth here? Yes, we are. No problems there. Okay, this is smooth here. No problems there. This is smooth here. No problems there either. So, if I'm not mistaken, I think we've rounded all of the available edges that we can round. We've finished the inlay. We rounded the internal bevel here, the axial bubble. On the second premolar with the onlay, we've rounded the internal portions of the axial and mesial and distal. We've also rounded the transitions from the onlay to the isthmus, the onlay to the isthmus, and then we've rounded the transitions from the onlay to the box, the onlay to the box, onlay to the box, onlay to the box, or shoulder to the box, as the case may be here. We've rounded off on the molar from the onlay to the box, and we've rounded off the little portion of the onlay of the distal lingual cusp to the inlay. We've rounded off this portion here in the mesial facial all the way around, and we double checked both areas here on the facial and lingual, and made sure that all of that is nice and round. And I think that that's a great way to finish this particular preparation sequence. So the next project we have is to prepare this second molar for a ceramic inlay. And I thought what I would do, because I think this is a pretty important concept, is to prepare the tooth for pressed ceramic and then modify the tooth for millable ceramic. Because the two preparations are not always the same. Well, let's put it this way. The millable ceramic preparation could always be pressed, but the pressable ceramic preparation cannot always be milled. And we're going to point out those differences. And it has to do with the milling burrs that are used in the milling machines. They have a certain dimension that will require certain parameters that are obeyed when we do the preparation. But as always, let's go ahead and start by removing the amalgam and assessing the remaining tooth structure. Okay. So I'm showing you the burr that I like to start with, and this is an 830L012. 830L012. It's a parallel-sided diamond with a rounded end on it, and it's approximately 3.5 millimeters long. It's a great burr to remove the amalgam because it's round-ended and it's short and it's easy to control. So we're going to go ahead and start with the amalgam removal. We've now removed the amalgam and we've assessed the remaining tooth structure. We made a decision not to use any type of base or blockout because the preparation is relatively conservative. So we're going to take at this point the burr to create the preparation. And remember, I'm going to first prepare this as though it was a pressed ceramic, and then we're going to make the appropriate observations and modifications to the preparation. So let's start with the 6881012. 6881012. This burr is essentially the KS2 burr, which is available also from Brasseler. So we're going to go ahead and start by developing the occlusal portion and developing a total occlusal divergence of about 10 or 12 degrees. And you notice how we're tipping the burr to the lingual side and tipping the burr to the buccal side, and then when we go around the distal, we're tipping it distally. So you really have to remember when you're prepping these you can't rely on the burr for all aspects of the preparation. There are certain features of the burr which are wonderful, but you still have to be a dentist. You still have to be a surgeon. You have to make these corrections. So I'm going to stop right here, and I'm going to show you this preparation, because this preparation could easily serve as a pressed ceramic preparation. And it has the necessary features. It has taper, which you can see all the way around. It has exit angles or angles of departure that are approaching 90 degrees or close to it. It has adequate bulk in the axial wall area, the width of the gingival at least being a millimeter. It's probably closer to 1.2 to 1.4 in this area. The depth is more than 2 millimeters. So it's all there, but it's going to be difficult to mill this. This could be pressed. The technician could wax this up easily and could press this. But there's some irregularity on the gingival, some little bumps that go up and down. And then there's some sharp edges in here, a sharp edge here and a sharp edge here, that might be difficult for the milling burr to get into those areas. So I'm going to go ahead and spend just a few more minutes modifying this preparation so it's maximally successful, utilizing the milling technologies also. The first thing we're going to do is we're just going to smooth this transition over here. And I think for this particular application, I'm going to use a 88012, which is the same burr in shape, but it's a finer grit. So it uses a 30 micron grit burr rather than a much more coarse grit. And so we're going to just use this burr to go ahead and round off that sharp area there, right there. Didn't take much effort. People say that the preparations for milled ceramics are so much more aggressive. I disagree. It's just a very subtle rounding of these little transitions make all the difference in the world. Right there. Now we know we can mill that, because if I can fit a 1 millimeter circle out here on the outside portion, I know that we can mill it, because remember, we have to imagine this is milling from the outside in, not from the inside out. Pressed ceramics are made from a wax up that starts on the inside. Milled is out of a block and needs to be carved from the outside. And then while I'm at it, I'm going to go ahead and continue to smooth the walls. And whenever I have a sharp edge, I'm going to just round that off just a little bit to make sure that we don't have any areas that would be difficult for the milling burrs to get access to. And at the gingival, let's make that finish line, that margin, absolutely smooth. And this is where it's time to move to a different burr, because this burr is just not quite capable of getting that perfectly flat. Okay? So what I'm going to do is I'm going to switch over to a different burr for that particular gingival portion. But before I do, let's just highlight the fact that now we have a smooth transition in here. And when the milling burr is trying to negotiate these areas, it'll have no trouble whatsoever. They're all nice and smooth. You just want to avoid any sharp angles that would be difficult for a 1 millimeter diameter burr to get access to. So you have to think about it from the outside. Can I draw a little circle right here that's 1 millimeter diameter that can negotiate that curve? I sure can. Can I do it over here? These are the areas you have to watch out for. Now down here at the gingival, we're going to go ahead and make this just a little bit smoother. There's a little bump over here that you could certainly press to, but milling to is going to be a little bit more difficult. So that's the reason why I'm going to go ahead and switch over to a burr that has more of a flat end. And this is the 8845 KR. And you notice this has got a really flat end, where the previous burr that I was using whether it be the coarse grit or the fine grit that I'm showing you here, it has more of a rounded end. I don't know if can you see that okay? So we're going to go ahead and stay with this flat-ended. Some people have made comments about utilizing end cutting burrs, and I think those are good too. This is a 10-839 burr, also made by Brasser, that's end cutting. You can see that the grit of the burr is right here on the end. So either one of these could be used. I happen to like the 845, 8845 KR018 because it's got the walls that are grit, and I can make some modifications to the walls while I'm in there. I can be more efficient. But you certainly could use the other burr. So this isn't going to take much effort, and this is clearly an area that you could use a slow speed or your electric handpiece on a slower speed. We're using air-driven turbines today. I prefer electric handpieces, but you can do this with any handpiece you like. And so we're just using the end of the burr in a very feather stroke, just going across that so lightly, so that finish line is as crisp as it can be. So I ask you, is the millable preparation more aggressive, or is it just maybe more refined? And I think that's something that we all have to kind of face when we're doing milled restorations, is that it's not a more aggressive preparation. I think it's probably, in my opinion, a more refined preparation. Okay, so I want to point out that when we're doing a ceramic preparation for a milled restoration, that would be like a chairside milled unit, whether it be your CEREC or your E4D, your preparation design has to be different than your pressed ceramic preparation. For example, this preparation design would work with any pressed ceramic system. But this would not work for a CEREC or an E4D milling procedure, because if this dimension right here is not at least 1 millimeter, it won't mill. It also cannot mill coming from a wide area into a narrow area like this. So on a CEREC prep, the modification to this preparation design to make it work for a milled restoration would be like this. You'd have to come here, and you'd have to come in here. You would remove this area, and you would widen that radius there, and widen that radius there. So the CEREC preparation would require those kinds of modifications. They're pretty subtle, really, but it's pretty important. The key is that the size of the milling burr that mills the restorations, and this is the diamond mill, this radius, actually I should say this diameter at this point, is 1 millimeter, okay? And we can't have anything on a preparation that's more narrow than that. It won't get milled. It's impossible. So, important to know. So this sharp preparation transition would not work with CEREC. This one would, because this burr cannot fit into that little point there. So it won't mill that. And if we look at this drawing over here, you can see this inlay design, it meets all the features, the requirements for inlays. Okay, it has good draw, and we can assume that this has good bulk. It approaches 90 degrees on the exit angles, and it approaches a 90-degree butt joint. Now the Sierra can mill in here just fine, but in this area, if this is 1 millimeter, if this is a 1 millimeter diameter burr, the burr cannot get into that little corner there. So that will be unmilled. And so when you go back to cement the restoration, try the restoration in, this area will be overextended. Even though the machine will design the restoration to fit into that area, even though the technology will allow you to mark the margins in that area, you can scan that area, you can't mill that area. And that's a very interesting problem. You can scan it, you can design it, you can marginate it, but you cannot mill it. You have to be able to do all of those in order to produce a restoration jarosite. So that's going to require a slight modification in your preparation design. I think it's an important thing to know.
So what I want to do is I want to share with you some very interesting techniques to approach the impression taking part of this a very enjoyable procedure of doing quality dentistry in the area of ceramics. So I'm going to first start out by doing a little self-promotion. I have a book here that we put together at UCLA called Clinical Dental Restorative Materials Guide, and it does cover all the materials that we use in the restorative dentistry clinic at UCLA. I put this guide together in 2011, and if you're interested in the guide, just watch the video. There'll be information on how to obtain it for your own use. I found it to be imperative for our students to utilize this and our faculty to put us all on the same page, and we essentially have in here descriptions and simple guides on how to use all of the products that we have at UCLA. So having said that, let me go into a little bit of a quick overview of some of the soft tissue management systems that we have available. The first one, of course, is retraction cords. Retraction cords are essentially divided into those that are knitted or braided and those that have impregnated or non-impregnated cords. And I'd like to show you the two examples of those that we use at UCLA. One we're going to show you is impregnated cords, and then the second one is going to be the non-impregnated cords and how they can both be utilized.
Well, many cords are available, and you can see they're all listed here on page 13 of our book. We even get into the details of exactly how much of the impregnated chemicals are located in the cords and exactly how much. So you can see in our book the exact breakdown of milligrams of each component in the cords. And I want to show you the way that this is distributed here is available in Unidose little packages. You can open these up, and these can be easily separated from the packages in a length that seems to work out pretty conveniently. And they even have this little area here where there's a little boundary, and that's used for hemostatic agents can be dispensed on top of this, and then they'll be contained within that area. And then the cord can then be used to place in the sulcus area in the sulcus. This is an example of a cord which is aluminum potassium sulfate impregnated. It's 10%, and which is a very safe anticoagulant to use. It doesn't have any systemic effects. It can be packed very easily and atraumatically as well. The other cord that the company makes, this is Dux Dental Van R company, is an epinephrine impregnated cord. This cord needs to be used with a lot more caution because of the fact that it does contain epinephrine. And even the small cord, which is the 0E size, it has 0.2 milligrams per piece of cord. So that's a fair amount, 0.2. When you consider that an entire cartridge of 2% lidocaine with 1 to 100,000 epinephrine only contains 0.018 milligrams, this has got 10 times more epinephrine in the cord than you would get in an entire cartridge of anesthetic. So an extreme caution statement here about utilizing any of the epinephrine impregnated cords. You're obviously going to be using these on patients that don't have compromised cardiac issues. So that's one cord that can be used as well. These are also available in other means of dispensing, little bottles. We have found these are not as easy to use in the dental school environment and probably in private practice also because of the issues of having to pull them out and clip them, and you're always handling the bottles. I really like the Unidose form. The Van cords are available in 0, 1, 2, and 3. And then the other cord systems that we use are the Ultradent cords, Ultra Pack. They come in sizes starting at 000, 000, 0, 1, and 2. They also make larger cords like the 3, which we have not used as much at UCLA. But these cords are pretty nice. They're hollow, and supposedly the material that can be added to them, the medicaments, will cause them to expand and push out the sulcus. I have my definite opinions about that. I have found that the Van cords seem to provide us with very, very good tissue retraction in a lateral component, but I haven't found that to be quite so with the Ultradent Ultra Pack system, but we are very successful at UCLA in using both of these. Well, these are some of the adjuncts to tissue management that we're talking about. The first one here that I have in my hand is made by Premier, and they refer to this as Traxident. It's a clay-based hemostatic agent, and it's composed of kaolin and 15% aluminum chloride, and it's supplied in these little 2.5 ml syringes. This is excellent to be used in cases where you want a very atraumatic tissue control. We can't place a cord in a case maybe of a thin phenotype of the tissue where cord placement is risky. This is an excellent tool to use. It's also helpful in cases where we have a lot of bleeding and we want to really stop the bleeding and provide for a very dry environment. So Traxident is very helpful for us for that reason. The next items, and let's skip over here to the top. This first item here is Viscostat, and this is made by Ultradent. This is a 20% solution of ferric sulfate. It's liquid, and it comes with a brush tip that can be added here. We have the same company makes a system called Viscostat Clear, made also by Ultradent. This is a 25% viscous gel of aluminum chloride supplied in the same syringe with brush tips that can be added as well. The Viscostat ferric sulfate solution that I talked about first is contraindicated with epinephrine impregnated cords. So you would never want to mix this system and this system together. They are not to be combined because it results in a black ink precipitate in the tissues and will discolor the tissues for several days, and it's a little frightening to see what can happen. So never mix the ferric sulfate with the epinephrine-based gingival cords. Okay, so whenever we're using an epinephrine cord, we use it with the aluminum chloride solution. The aluminum potassium sulfate cord impregnated systems can be used safely with any of the additional tissue management systems. Okay, so that's good to know. The next thing I want to show you is just another way of supplying a aluminum chloride solution, a hemostatic agent, and these are called Hemodets. They're made by Dux Van R. And the interesting thing about these, and they come with a couple of cotton pellets which you could use to place on top of your cord if you needed to. I have found that I don't typically use the cotton pellets. I just like using the gel in here. Now, it's a gel, and if you try to put your cord in this gel, it's so viscous that you really can't get it to stick to your cord. So what you need to do with this is you need to agitate it. So I'm going to just take a cord packer or a spoon, or you could use anything for this, and you just start agitating it. Stir it up. And it's a thixotropic material, so when we apply a load to the material, a shear force, it actually starts to liquefy. So now this product, which was too much of a gel is now very nice to use. It's easy now to dispense, and you can just go ahead and drip that onto a little plastic cover here that we have for the cords, and now the cords can then be covered very easily with the hemostatic agent. Once you've applied the hemostatic agent like this, go ahead and take the cord and wipe off the excess so that the cord is not dripping with hemostatic agent. So we can take the cord and then just pinch it in a little 2x2 here and use it in this particular fashion so that it's not dripping with the hemostatic agent. And we're now ready to place the cord in the sulcus. It works great. For inlays and onlays, you just need half of the length of this, so we usually cut this in half and use this in the interproximal areas. It's very effective. I'd like to talk about the cord placing instruments at this time. Okay, so these are two of the most effective cord packing instruments that we have. This one on the left that I'm holding right now is commonly referred to as a Greg 4.5. Hugh Freedy sells this as a PFIG 4.5. And it's got the bin angle approach, so you can use this and get around the corners, the distal linguals of teeth, and it's shaped a little bit like a plastic instrument. The end is rounded and fairly thin, and it can actually be modified and squared off into a flat end if you need to. Some people like to do that and modify the Greg 4.5. The other instrument that we find very, very effective is an instrument that's shaped a little bit differently. It's the ends are 90 degrees to each other. One end is flat here, and when we turn the instrument around, the other end of the instrument is coming up straight, so they're 90 degrees to each other. And this one is also a Hugh Freedy instrument called a GCPY D1. So GCPY D1. And the little end on this instrument can come in a serrated form or a non-serrated form, and this is actually great to be placed in the sulcus and pack the cords. So two instruments that I think are indispensable in your cord placing techniques. One of the wonderful techniques for taking impressions is the use of a quadrant tray. Now, some people criticize the use of quadrant trays because they believe that they're not as accurate for reproducing the occlusal relationships, but I would argue with that statement. In fact, the quadrant trays are taking a very dynamic and physiologically accurate impression because the teeth are allowed to touch as they do when the patient bites down. Obviously, they can't be used for full mouth rehabilitations, but for quadrant dentistry, where we have predictable guidance and a stable occlusion, we find them to be very, very effective. But it has to be a stable occlusion. In other words, MIP has to be working well. The patient has to be functioning without problems for these to be used. And when that occurs, they're fantastic. This one here is made by Emory. Emory Dental is operated by a dentist, and he's located in Oregon. And you can find the information about Emory either in our guide that I told you about earlier, or you can go ahead and Google that or something. Here's the way we insert this: a very thin piece of paper, and then we secure the interocclusal paper with a little piece of wax so the impression material will stay put, and put that on the other side as well, like that. That's pretty easy to do. You notice that I'm doing this in a way not to have any folds in here. I try to keep this straight. I'm sure some of you are thinking, why fool around with a metal tray that has to be sterilized and cleaned on a regular basis? Why don't I just use the disposable trays? Well, the answer for that is real simple. They just lack the rigidity that we have found is necessary for complete accuracy. The disposable trays are probably very accurate. I can certainly think that they could be used effectively most of the time, but this tray is proved to be so accurate that in our at UCLA we have less than 0.5% of remakes that can be attributed to distortions of impressions. Less than 0.5%. That's a remarkable statistic, and we've attributed that to a very strict protocol, and one of the things that we believe is important is this stiff tray. We found the following dispensing syringe to be very, very helpful for students and for anybody wanting to have full control of the injected portion of the syringe material in the impression taking process. So while your dental assistant is loading the tray, you can be injecting around the tooth independently of the dental assistant. Some people like to use a large delivery system like this with an extension and a tip attached to it. Well, we found that lacks the control. You're out here with a trigger that's about 6 to 8 inches away from the tooth itself, and you lack the accuracy that you need, the precision to place the material exactly where you need to place it without capturing any voids. And that's what we're talking about here, is excellence in dentistry, taking things to the next level and finding a way to not have mistakes occur in your daily practice routine. So with that in mind, we like to use a very small syringe like this. So here's how this works. This is made by Ho Dental, H-O Dental. They're operated out of Las Vegas, Nevada. And this little cylinder here gets filled with the impression material, the light body. So I'm going to express the light body into my 2x2 so that I know I have equal amounts. So in other words, I bleed the cartridge. And then I'm going to take the syringe and hold it up against the ports here of the larger impression material cartridges and just slowly squeeze out an equal amount. And when I get to about 1/4 of an inch from the end, I stop. And then you can see that I have an equal volume of both the catalyst and base and the syringe material. Then the plunger is then added to the cartridge container and pushed in, and you notice that just a little bit will come out the end. At this point we can take a 2x2 and just wipe that off so that none of the material mixes with itself. And now this syringe is loaded. At this point you can take the top of this syringe and then push it all the way over like this, and it clicks into position, and now it's ready to go. There's a mixing tip here that adequately mixes the syringe material contents, and a little tip here on the end that rotates around. And it's a small tip, and it can be used so now very effectively in small areas like boxes and what have you when you're trying to capture impressions. And notice how close we are to the tooth in this particular case, 2 or 3 inches away from the tooth, and we're using a syringe, and dentists know how to use the syringes. We're very adept at using syringes, we're used to it, and we can have a lot better control in placing our material compared to the clicking of a gun where we're 6 or 8 inches away from the source. So these are fabulous. These can be set up many hours before you're ready to use them, in fact days, because the material is stored very nicely. It's not going to be contaminated by touching itself and pre-setting or anything like that. And that's how we use the hose syringe. Okay, so now we're ready to take the impression, and you might think that you must remove the rubber dam to pack the cord, and nothing could be further from the truth. So, you know, in the mouth, obviously you'll be using little different tools and what have you, and we've used a double dam in this particular case, but what we do is we just take the scissors and we cut away the rubber dam in the area between the teeth, the septal areas, and make sure that when you cut, you're not cutting through tissue. And we just cut like this, and but we leave the rubber dam in place on the other teeth, and we're going to go ahead and continue to cut this. The septal area is removed, and the rubber dam is still in place. This is a tremendous advantage for us because we can pack the cord with the rubber dam still in place, and the patient is not going to be tasting any of the medicaments of the cord as we place the cord. We like to pack the cord in little segments like this, one after the other. In this particular quadrant, would need to have 1, 2, 3, 4, 5 cord segments, one for each of the box areas. And and once the cord is placed, you can then remove the rubber dam. And if we're going to do a double cord technique, we would then take usually a larger cord and then just place that on top of the previous cord by going across the area of the sulcus interproximally. One of the things we found to be very helpful is to make sure you go around the corner. When you take an impression of an inlay or an onlay, don't just go to the edge of the box, but go around the line angle on both sides. So you can see that you can place the cord. In this particular case, we've used a double cord. There's a size 0 and then a size 3 on top, placed in the sulcular area with the rubber dam still in place. In this particular case, we would place cord on the distal of the premolar, on the mesial and distal of the second premolar, on the mesial and distal of the molar. And it's so easy to do. The patient doesn't have to taste any of the medicaments, any of the ferric sulfate, or maybe the aluminum chloride that we used, and we have really good retraction. It just doesn't get any easier to place cord than when you have the rubber dam in place. Once the cord's all placed, then we can remove the rubber dam, allow the patient to relax their bite for a while, maybe rest their jaw on a 2x2 while we prepare ourselves for the impression, which will be our very next step. Okay, we're now removed all the cords and we're removing our last cord, and we're now ready to take the impression. It is sometimes a good idea to leave the bottom cord in place. Make sure you, at this point, you rinse the area, dry the area, and keep it dry. We've found that as long as you keep the area dry, constantly blowing the area with syringe, it's going to stay nice and clean, and it won't bleed, and you'll be able to take a beautiful impression. Now we're ready to take the impression, so you or your assistant will then express the heavy body impression material up against the paper on the tray. And you notice that I try to keep the tip down and overlap my strokes so that I don't have any voids. We then turn it over and go ahead and do the same thing on the other side. Don't overload the tray. You don't need to waste impression material. Impression material is expensive, and it doesn't bode well to use too much. That's all we need. I basically have a standard of keeping this fairly level with the top edge of the emery tray. That's about all the material we need for any impression. And now we're going to go ahead and we're going to impress the teeth. We're going to start by putting the syringe in the deeper areas and working around the tooth, keeping the tip pushed up firmly against the tooth the whole time. And I like to flood the entire tooth, not just the areas that you prepared, but all the areas. The areas that you did not prepare are just as important because they could provide valuable information about contours of the restoration. So no voids anywhere on that tooth. I like to use the word flood the tooth. Completely cover all of the preparations and all of the teeth with impression material. And we're just about done with this one syringe, and we can just kind of get it to cover using all the last little bit here. At this point, we're now ready to insert the emery tray. The tray comes in. We insert the tray first, and then the patient occludes. I realize that this is on a typodont, but one of the things we do to make sure the tray is fully seated is we ask the patient to bite down on their back teeth. Now, sometimes they have a hard time doing this. They're confused. This is a big bulky tray in their mouth. There's a lot of material in there. They're numb. There's a lot going on. And a trick that I have learned works is to place your finger on the canines or premolars opposite of the arches you're working on and push, and ask the patient, do you feel where I'm pushing? And they'll say yes. I'll say close down so those teeth touch. And it's remarkable. Every time they'll find their home base. It's incredible how effective this is. It must give them some kind of a proprioreceptive anchor to rely on, and then their teeth will just go right into MIP without any trouble whatsoever. When the impression material is placed, we do want to support their jaw for the 4 or 5 minutes or so that it takes for the impression material to set, and make sure that they're supported. This is a good time to start to talk to them a little bit about what to expect in the temporary phase. Good time to bond with your patient and give them instructions. It has now been 5 minutes since we placed the impression tray in the mouth. At this point, we're going to go ahead and have the patient open. So they're going to open their mouth rapidly, and the impression will usually come away from the teeth that we've prepared if we push in the right direction, which is desirable. And then we're going to lift the tray off the opposing arch, have the patient bite, relax, get suctioned, and comfortable. The hard part's over for them. At this point, we then can inspect the impression, look for any errors, any voids, any areas that we didn't capture the impression perfectly. One of the core values in our practice is that we just simply don't send an impression that isn't ideal to the laboratory. All the details should be captured. All the margins should be captured properly. No bleeding, no voids, no issues that could in any way compromise the laboratory result. Remember, the laboratory can only make a casting or a pressed ceramic restoration fit the die. They can't make it fit the mouth. That's our job. They can only fit the die. The die accuracy depends on our ability to take an accurate impression. One of the things that we have found is very helpful when taking an impression of a mandibular preparation, we're going to just assume that we've done some preparations here on the lower right, and the tongue is oftentimes going to drape over the teeth and make it difficult for you. So you can certainly have the dental assistant take a mirror and retract the tongue this way and hold the tongue for you while you're holding the cheek this direction. That's fine. But another system that you can use, and I found this to work out really well, is to use your fingers and retract the tongue with your finger, pushing it this way, and the cheek with your thumb, and then holding these in this manner. Then you can inject around the preparation like this, however it needs to go, and then take the impression tray, and we're using the one that we used on the upper just to demonstrate this. Insert the tray onto the preparations like this, and pull your fingers out, and then it's fully seated. The tongue has still not been allowed to collapse, and then we can close, have the patient close, and never does the tongue invade the preparation and result in any of the typical problems we see when the tongue slides over and hits the preparation that's been covered with impression material. We find this to be very effective. Okay, it's now time to place our provisionals. And we're going to use a very simple technique, and there's actually a nice YouTube video on this Duraseal technique if you want to look at a more detailed discussion of it. But basically we're going to use a dental stopping material in the interproximal areas to cover over the tissue, and that will stay in place, and then we're going to cover that with this Duraseal product right here, which is a polymethyl methacrylate with plasticizer, so it never gets perfectly hard, and but it holds the teeth in position, protects them, and it is very nice for protecting the enamel margins of your preparations. But the first step will be to warm up the gutta percha material and place that in between the teeth to protect the tissues from the effects of the polymethyl methacrylate. We're now going to go ahead and place the gutta percha. It's been warmed up, and it can then just be inserted in between the teeth like this. It seems kind of crude, but it works quite well. Just keep it in the proximal areas. It is going to cover over the tissue and protect them. The purpose is not to fill these boxes up too much, but just protect the tissue like that. And then I'm warming up another piece here, and another piece gets warmed up and then inserted interproximally between the teeth thusly. And then I have a third piece that I'm warming up here, and we can go ahead and put this piece in the back over here like this between the last two teeth, and just wipe off the excess like this. It's not a very delicate procedure. It's a rather quick procedure to do, certainly one that can be delegated to an assistant with no worries whatsoever. They'll do it quite well. At this point, once that's done, we're now ready to start using the DuraSeal liquid and powder. And we're going to take the liquid and on a brush, a bender brush, and pick up some of the powder, and then just kind of wick it in there, allow it to sort of carry up into it, and then just sort of wipe it off like that, and just pull it forward into the adjacent tooth. Continue wicking it like this and adding the DuraSeal. It just goes on real easy, doesn't it? Not a big deal. Even a big onlay like this one back here can be temporized very quickly. And I know what some of you are thinking. You're thinking, why mess around with this stuff? Just use Fermit. Fermit is so easy. And I can tell you that I agree. The Fermit is easy. But Fermit is expensive. And this product is very, very inexpensive. Another advantage is that this product never gets fully hard. It stays a little bit rubbery. It's sort of like the consistency of a denture soft liner material when it's set. And this allows you to remove it so easily. And Fermit at times we have found is a little bit more challenging to remove when it gets locked into teeth. So we just do it like this. And look how simple that was, just to temporize a whole quadrant of inlays in a matter of seconds, really. If we want to add a little bit more, we can build up this cusp over here and basically make them look a little bit more like teeth. Not that critical to do, as long as we've covered the margins. They're all connected together in one big solid piece. At this point, we now have the patient bite down together, and they'll close several times, and they'll get the occlusion worked out. By doing that, you can then use your finger, either dipped in a little bit of the monomer, and just use it to sort of pack it in place, keep it from being squished all over. And there's no occlusal adjustment to do other than that. The patient's now ready to leave your office. What's the disadvantage? They can't floss. Is that really a disadvantage? We have found that it isn't. In the short time it takes to go from temporary to final restoration, the gums are not irritated. The gutta percha stays underneath. It protects the tissues from any of the irritants in the polymethyl methacrylate product. When we come back in 2 weeks or so to remove this, we just flip this right out in one big piece. You'll see in the next step of the video. So we've taken you from the original diagnosis, the initial diagnosis, the disassembly of the restorations, the blockout, the lining procedures, the blockout, the preparation, the burrs that we use. We've gone through impression materials, cord packing, tissue management, impression taking, and now finally provisionals. So we've gone a long way, but we have a lot more interesting things to talk about, so stay tuned. It has now been 1 to 2 weeks since the preparations were completed, the impression was made, and the temporary restorative material was placed. In this particular case, the restorative material that was used as a temporary is DuraSeal on top of dental stopping, which is essentially gutta percha. It's fairly easy to remove even after it's been in the mouth for a couple of weeks because the product never gets fully hard like normal polymethyl methacrylate. You can see that it can be lifted off and reveals underneath fairly healthy tissue. One of the incredible things about DuraSeal is that it is so protective of the margins of the preparations, and then the dental stopping material, as we can see here in the distal of the molar, actually helps to displace the tissue. It's an interesting benefit from the material. We know that it protects the tissues from the toxicity of the polymethyl methacrylate, but it also does a great job in displacing the gingival tissues, which facilitates rubber dam application and cementation procedures. So we just spend a couple of seconds really usually popping out the materials, and now we can apply the rubber dam and proceed with the cementation.